Good day. So we will now present risk and health, specifically the elderly with cardiovascular diseases. So our learning objectives. Next, for our introduction, in the Philippines, the elderly ages 60 and above now accounts for 11% of total population and is now very vulnerable to cardiovascular diseases. Because aging increases the risk of hypertension, coronary artery disease, and stroke, while social challenges such as limited access to healthcare and economic insecurity worsen their condition. These factors contribute to poorly managed cardiovascular conditions and resulting in higher mortality and decreased quality of life. To address these growing problem, culturally sensitive and community-based interventions are needed to improve prevention, early detection, and care for elderly Filipinos at risk of cardiovascular disease.
So now I'll be discussing the nature and perception of risk among the elderly population with cardiovascular disease. So first, it is important to understand the difference between the actual risk and perceived risk. The actual risk is the real and scientifically proven chance of developing an illness, and it is based on medical evidence. For example, na studies nag-show siyang ang elderly Filipinos have a high probability of cardiovascular problems because of the factors like aging, hypertension, diabetes, and even genetic predisposition. And this is what the doctors and health professionals measure using tests, statistics, and patient histories. On the other hand, perceived risk is how the people personally view their likelihood of getting sick. This perception is still always nag-match reality because naka-influence siya sa people's personal beliefs, cultural attitudes, and even family experiences. And example, some elderly nagaingon sila na okay na ko, dili na sakit akong dughan even if their blood pressure is already high. And others might think that having no symptoms means they are not at risk, where in fact cardiovascular disease can be silent until it becomes severe.
Next is for reference theories or models explaining risk perception. First is the health belief model or HBM. This theory says people's actions about health depend on how much they think they are at risk and how serious they believe the illness is. For example, if elderly Filipinos believe heart disease is just a normal part of aging, they may not take steps to prevent it. But if they see it as a dangerous condition, they are more likely to eat healthy, exercise, and go checkups. Next is risk perception theory. This theory explains that people's view of risk is not always based on facts, but also in feelings, culture, and personal experiences. For instance, an elderly person who saw a family member suffer from heart disease may feel more at risk, even if their own health is fine compared to someone who never witnessed it. Next is protective motivation theory. This theory says people are more likely to protect their health when they are made aware of the danger, believe the advice given will work, and feel confident they can follow it.
So now I will discuss the biological risk factors of cardiovascular diseases in elderly. So first is age. Growing older weakens the heart and blood vessels, making seniors more prone to CVD. Second is family history. Having relatives with heart diseases, hypertension, and stroke raises the risk of this kind of diseases. Third is gender. Men are at high risk while women become more vulnerable after menopause. Next is comorbidities like diabetes, kidney diseases, and hypertension further increase the chance of heart problems. Lastly, natural aging causes stiff blood vessels and weaker heart functions, adding to the risk. So in summary, age, genetics, gender comorbidities, and aging changes all contributes to cardiovascular diseases in elderly.
The next will be the environmental risk factors. First, we have inadequate transport systems. This restrict the access to hospitals, health centers, and community activities. And the next will be the poor housing conditions. This is the unsafe flooring, poor lighting, and absence of elderly-friendly facilities that will increase the risk of falls and injuries. The next will be the limited access to healthcare services. This is caused by high cost, long distances, and lack of culturally sensitive care. And the next will be the urban migration of younger family members. This reduces the caregiving support, leaving some elders socially isolated. And the next will be the environmental hazards. This includes the air pollution, overcrowding, and unsafe neighborhoods that heighten the risk of respiratory and cardiovascular diseases. And then lastly, the inadequate community infrastructure. This is the lack of parks, recreational spaces, and elders friendly public facilities reduces opportunities for physical activity and social engagement. Next will be the behavioral risk factors. First, we have unhealthy lifestyle habits. This includes the poor diet, which is high in salt, sugar, and fat. This includes the smoking and excessive alcohol intake that will increase the risk of chronic diseases like hypertension, diabetes, and cardiovascular problems. And the next will be the physical inactivity, the sedentary lifestyle that contributes to functional decline, muscle weakness, obesity, and mobility limitations. And the next will be the poor medication adherence. This includes forgetting, refusing, or inconsistently taking prescribed medication due to cost, lacking of knowledge, or cognitive decline. Next will be the delay in seeking medical care. This often influenced by fear, financial challenges, or underestimating early symptoms. And the next will be inadequate coping mechanism. This is the reliance on passive strategies instead of engaging in health stress relieving activities, which may lead to depression or anxiety. And the next is the dependency behaviors. This is the over-reliance on caregivers for activities which can diminish independence, confidence, and self-efficacy.
So now we're going to proceed on risk communication and reduction strategies. So first, communication strategies. Second is evidence-based risk reduction strategy, health promotion theory or models, community and health involvement. So first is communication strategy. Effective risk communication ensures communities understand health risk and know what action to take. Messages must be clear, timely, and two-way, allowing people to provide feedback and raise concerns. So, the trust is built through reliable messengers such as nurses, BHWs, community leaders, and local media. So, the World Health Organization emphasizes strategies like audience analysis, co-creation of messages, feedback loops, and cultural adaptation. When these are applied, communities are more likely to trust and follow health advice. This strengthens both regular health programs and emergency responses. So next is the risk reduction strategy. So the risk reduction strategy combines health education with self-management support to improve health outcomes. So for hypertension, self-measured blood pressure monitoring with team-based care has proven effective. So digital tools such as SMS, reminders, and mobile apps also enhance adherence, especially for underserved groups. Community-based programs like group exercise, healthy food initiatives, and lifestyles coaching encourage healthier habits. So together, these strategies reduce cardiometabolic risk and strengthens ties between communities and health systems.
Health promotion theories or models. Program design in community health should be guided by established frameworks to ensure interventions are structured, evidence-based, and effective. There are two widely used models that are Proceed model and the Social-Ecological model. So the Proceed model is a comprehensive planning framework that starts with assessment and it ends with evaluation. It helps identify predisposing factors such as knowledge, attitude, and belief, and also enabling factors, resources, skills, and accessibility. The reinforcing factors like feedback, rewards, and social support that influence health behaviors. So this model ensures that the intervention are not only implemented but also systemically evaluated for effectiveness. So each structured approach has been proven successful across many community health interventions worldwide. On the other hand, a social ecological model emphasizes the health behaviors are shaped by multiple levels of influence from the individual to the family, community, and the broader policy environment. It recognizes that sustainable changes cannot rely solely on individual behavior, but must also address the social determinants of health, like SDOH. such as economic condition, education, culture, and healthcare access. By targeting multiple levels, this model promotes strategies that align individual choices with support and community and policy environments. Community health involvement. So barangay health workers serve as pivotal frontline connectors between the healthcare system and the community. They are often the first point of contact at the barangay level, responsible for outreach, follow-up care, and providing culturally sensitive counseling that resonates with local belief and practices. They also have evidence from the Philippines and other global settings consistently shows that when community health workers, CHWs, and BHWs are effectively engaged, there are significant improvements in healthcare access, continuity of care, and adaptation of risk reduction and behaviors. For example, BHWs help ensure timely medication delivery, facilitate vaccination scheduling, and also support families in maintaining preventive healthcare practices.
Good day everyone! So for our subtopic, we applied Pender's health promotion model in caring for elderly clients with cardiovascular disease. So this model po, gina-highlight niyo po yung role ng perceptions, past experiences, and self-efficacy in shaping health behaviors. And for our older adults, it means po na gina-encourage po natin sila to adhere to their medications, engage in safe physical activity, and also to follow a heart-healthy diet to support their condition. However, many elderly clients po, nag-face po sila ng mga barriers na nag-affect sa kanilang mga health maintenance. And nag-include po dito yung fatigue, dependency on others, and lack of confidence. Nevertheless, andyan po yung Pender's model where it emphasizes the need for motivation and empowerment to help clients overcome these challenges and sustain positive health behaviors.
ORM self-care deficit nursing theory. To strengthen this approach, we also look at ORM self-care deficit nursing theory. Unlike Pender's model, which focuses on motivation, ORM highlights the role of nursing support when clients cannot fully function to their own needs. And elderly patients with CVD, this includes assistance with medication management, vital signs monitoring, and balancing rest with activity. For the integration of models, overall, these two frameworks complement each other. Pender's model empowers clients through education and motivation, while ORM ensures they are supported in areas where they are struggling with self-care. By combining both, nurses can provide holistic care that addresses both the behavioral and functional needs of elderly clients with cardiovascular disease.
For conclusion, heart disease is a major threat to older Filipinos, often caused by aging, unhealthy habits, pollution, and limited healthcare access. Conditions like high blood pressure, stroke, and heart attacks are common, yet many delay treatment, believing symptoms are part of aging or due to financial and cultural barriers. Through health education, lifestyle changes, and strong family and community support, early detection and prevention can be achieved, reducing hospitalizations, lowering risk, and improving the overall quality of life for the elderly.